I'd like to thank SAGES for the opportunity to present our research today. My name is Timothy Vreeland. I'm a surgical oncologist at Brooke Army Medical Center, and I'll be presenting our abstract on postoperative outcomes for patients with liver-related ascites undergoing non-emergent laparoscopic cholecystectomy. I have nothing to disclose. In the last 2 decades, death rates from chronic liver disease in the United States have been steadily increasing. This is a graph of CDC statistics showing an increase in the death rate from chronic liver disease, particularly in the 45 to 64 age range. The majority of this increase in the United States is due to non-alcoholic fatty liver disease, which has doubled over the last decade. As a result of this increase, general surgeons around the country will be seeing more patients with chronic liver disease and need to be prepared to deal with general surgical emergencies in these patients. Of note, cholecystectomy is the most common operation performed on patients with cirrhosis. As a result, general surgeons must be prepared to treat cirrhotic patients with gallbladder disease, as this is the most likely disease general surgeons will treat in a cirrhotic patient. While there are small series that have looked at the question of safety of cholecystectomy in cirrhotic patients, these are generally from tertiary referral centers where surgeries are being done by hepatobiliary surgeons or transplant surgeons. However, there is not much literature on these operations being done in the community by general surgeons. Given the rarity of this issue, particularly in the hands of a general surgeon, a large database may be the best source to examine this question. To do this, we examined data from the American College of Surgeons National Surgical Quality Improvement Program, or ACS-NSQIP. We looked at patients 16 years or older who underwent surgery between the years of 2005 and 2017. We divided patients into 2 groups, those with and those without liver-related ascites. We included 402,330 patients who were age 16 years of older and underwent a laparoscopic cholecystectomy with or without intraoperative cholangiogram between the years of 2005 and 2017. We excluded 56,255 patients for the following reasons: emergent surgery, on ventilator, preoperative septic shock, ASA class 5, primary surgeon was not a general surgeon, and patient not admitted from home. The purpose of these exclusion criteria was to try to get a realistic cohort of patients who were undergoing non-emergent surgery where general surgeons would have the time to either refer to a tertiary referral center or to do the surgery themselves. After these exclusions, we had 105 patients left. Of those patients, 591 had liver-related ascites, while the remaining patients had no ascites. We then performed propensity score matching based on the following characteristics: age, sex, BMI, inpatient-outpatient status, ASA class, the 5-item frailty index, preoperative sepsis, and smoking. After matching at a ratio of 5 to 1, we were left with 3,546 patients. 2,955 had no ascites, while 591 had liver-related ascites. We'll now move on to our results. This is a busy table, but I'm going to try to go through the important things. So first of all, comparing patients with and without ascites, we see that patients with ascites had more dyspnea, more bleeding disorders, and more disseminated cancer. We also see that they underwent more preoperative transfusions. In general, we see that these patients with ascites were sicker than those without. We also see that the operations took longer. While this was only a 10-minute difference, it does show that these operations were likely more difficult due to the patient's liver-related ascites. So the take-home from these results: patients with cirrhosis and ascites have additional comorbidities, and surgery is more difficult in these patients. Now moving on to postoperative outcomes, we see that there are a number of significant differences, and we'll go through these. So first of all, we see that patients with ascites had a much higher rate of morbidity at 16% versus 11%, and this was true of minor and major morbidity. We also say that there was an increased mortality rate, an increase from 1.5% to 3.6%. Again, not a dramatic increase in mortality. However, we're talking about non-emergent laparoscopic cholecystectomy. A mortality rate of 3.6 is very significant. We also see more fascial dehiscence, as well as more perioperative transfusions. Additionally, we see a length of stay of 7 days versus 4.4 days, which, again, for a laparoscopic cholecystectomy, a postoperative length of stay of 7 days is pretty dramatic. At this point, we knew that patients with liver-related ascites had worse outcomes than those without, but we wanted to see if MELD had an effect on these outcomes as well. So we broke patients with ascites down into those with a MELD less than or equal to 9 versus those with a MELD greater than 9. So you see the non-ascites group, ascites MELD less than or equal to 9, and ascites with MELD greater than 9. The theory here being that likely the majority of the morbidity of the patients with ascites was actually in those with higher MELDs. As you can see, the patients were again matched here. So we have 155 in each of the two ascites groups versus 775 in the non-ascites group. Going through some postoperative outcomes, going through some intraoperative outcomes, the mean operative time was roughly the same in the two groups with ascites, but they were both significantly longer than the group with no ascites. Looking at outcomes, we see that morbidity was dramatically higher in the patients with the MELD greater than 9 at 26% versus 16 in no ascites and 11 in the ascites but low MELD group. This trend will continue. So major morbidity, we see the same trend, 16% in those with MELD over 9, 8.5 in those with no ascites, and the lowest is 6.5 with ascites but a low MELD. Length of stay, we see 9.6 days for those with ascites and a high MELD versus 5.5 and 7.6 in the other two groups. So again, we see after a non-emergent laparoscopic cholecystectomy, a length of stay of almost 10 days in the group with ascites and a high MELD. And then finally, looking at mortality, the perioperative mortality in the group with ascites and a MELD greater than 9 was 7.1% versus 3.1 with no ascites, 1.9 with ascites but a low MELD. So again, just for a non-emergent laparoscopic cholecystectomy, we're talking about a mortality of 7.1%, which is pretty dramatic. So again, when we break these patients down based on MELD, we see that the increase in morbidity and mortality is really just concentrated in those with a MELD greater than 9. Again, mortality rate of 7.1% in that group. The conclusions of this study are that patients with cirrhosis and ascites are at significant risk of both morbidity and mortality, even from a simple general surgery procedure like a laparoscopic cholecystectomy. This is particularly true of patients with a MELD greater than 9. General surgeons should proceed with caution with any patient with cirrhosis and ascites who needs a laparoscopic cholecystectomy. However, they should really consider transferring patients with a MELD greater than 9 to an HPB or transplant surgeon. And this may not even be just about transferring to a specific surgeon, but transferring to a center that has the ability to perform a transplant, that has the support to take care of these patients who are obviously very sick and will have significant complications after surgery. I want to again say thank you to SAGES and to the selection committee for the opportunity to present our research today. I'm happy to take any questions over email. My email is at the bottom there. Thank you all for your attention.